We are so happy to have Dr. Tiersten join us today. Just a little bit about Dr. Tiersten is that she is a professor in the Division of Hematology and Medical Oncology and a member of the Breast Cancer Medical Oncology Program. Dr. Tiersten sees patients in the Dubin Breast Center. She works collaboratively with Mount Sinai interdisciplinary teams to provide care to breast and gynecologic cancer patients. Dr. Tiersten has extensive experience participating in clinical trials as well as being the principal investigator in national studies. So we are so lucky to have her. Thank you so much for taking the time. And I will hand it over to you now. And for those of you who just joined, please feel free to put any questions in the chat. Thanks.
Okay. Thank you so much for inviting me, and thank you all for taking time out of this balmy Wednesday. It's a little bit of a hodgepodge of topics here. I just picked a few things that might be a little bit off the beaten path, with most of the focus being on endometrial or uterine cancer. So basically, endometrial cancer is the most common gynecological cancer in the United States. It's important to note that about 75% of patients are diagnosed with early stage disease that's typically curable with surgery. And that's because unlike ovarian cancer, for which there's no screening, there's no early warning signs, typically endometrial cancer presents with abnormal vaginal bleeding. So there is an early warning sign. Patients with advanced or recurrent endometrial cancer after primary treatment have more limited treatment options. And just to highlight that there are two basic subtypes of endometrial cancer. Type 1 accounts for about 60% of endometrial cancers. And these are cancers that we call low grade, which means when the pathologist looks under the microscope, they assign a grade to a cancer. And cancer can be either low grade, intermediate grade, or high grade, which is also known as well differentiated, moderately differentiated, and poorly differentiated. And that's a measure of how different from normal cells the cancer looks under the microscope, how aggressive the cells look, if you will. So the type 1 or low-grade cancers have a higher likelihood of responding to hormonal therapies. And type 2 endometrial cancers tend to be high-grade or poorly differentiated, look more aggressive under the microscope, don't respond so well to hormonal therapies, but they're very responsive to chemotherapy. Oops. Okay. So in terms of just broad strokes, in terms of the history of treatment, up until the early 2000s, whole abdominal radiation was often used as adjuvant therapy. And when I say adjuvant therapy, I mean therapy after surgery to help reduce the risk of recurrence. And that was sort of the standard of care up until the early 2000s. Whole abdominal radiation is a large area to radiate, and does have a lot of side effects to bowel and bladder and other organs that are incorporated in the field of whole abdominal radiation. In 2006, it was shown in randomized trial that chemotherapy was superior to abdominal radiation in terms of decreasing the risk of the cancer coming back. Carboplatin and paclitaxel emerged as an effective and less toxic regimen as compared to some older regimens, which included chemotherapy agents that had more side effects, and became the standard of care in the frontline setting, and actually to this day remains the standard of care in the frontline setting after surgery. Chemotherapy tends to work less well after the frontline setting, and better alternative therapies are needed in this population. So let's talk a little bit about DNA mismatch repair. That's a common topic of interest when talking about endometrial cancer. So DNA mismatch repair is essentially a system for repairing errors that can arise during DNA replication. So all of our cells are constantly undergoing errors when they replicate. And it's important for a cell to have the ability to repair those errors that can arise during DNA replication. And about 25 to 30% of patients with advanced endometrial cancer have a mismatch, what's called a mismatch repair deficiency found in their tumor. And this is something that we find when we do what's called genomic or somatic profiling of the cancer. And this mutation is actually associated with a better response to what's called immunotherapy. So immunotherapy is a real game changer in oncology in general. Immunotherapy is an amazing type of therapy that actually unleashes a patient's own immune system to fight their cancer, and works best when there are more mutations and errors found in the cancer cells. That kind of makes sense because your immune system can better recognize cells that are different or quote unquote wrong as compared to normal cells. And that's why having a deficiency in the ability to repair DNA errors makes immunotherapy work best. So basically, cancer cells are very evil and know how to put out a signal to cancer cells to kind of, cancer cells are very evil and know how to put out a signal to your immune system to be able to hide and evade your immune system. And a category of drugs, which are one of the main categories of what we talk about when we talk about immunotherapy, are called checkpoint inhibitors. And these drugs are quite brilliant in that they have the capability to release that brake that cancer cells signal to your immune system, thereby unleashing a patient's own immune system. So this is a form of biologic or targeted therapy, quite different from something like classic cytotoxic chemotherapy, where we're killing cancer cells, we're killing some normal cells. Here we're, as I mentioned, taking a patient's own immune system and unleashing its ability to fight cancer cells. So hold on one second, I apologize. Hold on. I can't see what year this was, maybe because my little floating, what does it say, May of what, 2017. 2017. Thought it was around there, but I didn't want to give the wrong date. So the FDA granted accelerated approval to pembrolizumab, which is one of the checkpoint inhibitors. It's one of the immunotherapy checkpoint inhibitors. And this was really the first time that FDA granted approval of a pharmaceutical based on this, a biological finding within the tumor. So pembrolizumab was FDA approved based on a tumor having this problem with repairing DNA errors or mismatch repair deficiency that have progressed following prior treatment. So that includes all types of cancer, colon cancer, breast cancer, any cancer that has this mismatch repair deficiency. And so this is what we call an tissue agnostic indication, meaning really the first time that a drug was not approved for breast cancer or ovarian cancer or a specific type of cancer, but rather a biological finding within the tumor in many different types of cancer. So following that FDA approval, in 2017, pembrolizumab was a common second-line drug in endometrial cancer patients who did have mismatch repair deficiency. So we wanted to be able to extend the benefit of immunotherapy to more than just the 25 to 30% of endometrial cancer patients who do have this mismatch repair deficiency. And as I mentioned, pembrolizumab is used by itself as a treatment for endometrial cancer that has mismatch repair deficiency in the second line or later setting. Lenvatinib is an oral drug that works primarily as an angiogenesis inhibitor. So what is an angiogenesis inhibitor? It's another biologic or targeted therapy that acts by inhibiting a cancer cell's ability to grow its own blood supply. And other drugs that are within this category you may be familiar with, bevacizumab, otherwise known as Avastin, is also an angiogenesis inhibitor. And so initially in mouse models, it was shown that this angiogenesis inhibitor, lenvatinib, plus immunotherapy had more potent anti-tumor activity than either agent alone. So they were additive or synergistic. And based on the finding in mouse models, a trial was launched in recurrent endometrial cancer patients, regardless of whether or not they have that mismatch repair deficiency status, and the combination was highly active in all recurrent endometrial cancer patients. There are some significant side effects with lenvatinib and pembrolizumab. Most common side effects with the lenvatinib are hypertension, fatigue, decreased appetite, mouth sores. And side effects of pembrolizumab, or side effects of immunotherapy in general, are that sometimes immunotherapy drugs can rev up your immune system too much, such that it attacks normal cells. And you can experience inflammation of any organs on the basis of that. So it's not uncommon to have hypothyroidism, or your thyroid affected by immunotherapy drugs. That would be inflammation of the thyroid gland. You can develop colitis due to the effect of immunotherapy on the colon, and on, pretty much any organ, pneumonitis involving inflammation of the lungs. These are relatively uncommon side effects, but they're there. And more so, the lenvatinib adds a lot in the way of side effects. And although the FDA approved dose of lenvatinib in that clinical trial was 20 milligrams, it's very common to have to reduce the dose of lenvatinib in patients in whom you're treating. The average dose of patients in the study was actually 14 milligrams. So a good proportion of patients needed to undergo dose reduction. And then there was a head-to-head trial comparing this completely non-chemotherapy-based regimen of combination lenvatinib and pembrolizumab to standard chemotherapy in the second-line setting. And this completely biologic non-chemo regimen was superior in effectiveness to chemotherapy in the second-line setting for recurrent endometrial cancer. So based on this, I think this is July 2020, but again, I can't see it. It's obscured. Is it 2020 or 2021? Sorry. The FDA granted regular approval to this combination of pembrolizumab and lenvatinib for advanced endometrial cancer, regardless of mismatch repair deficiency in the tumor. So, and that is, again, for patients who have disease progression following prior systemic therapy, based on that randomized trial that showed this to be more effective than chemotherapy in this setting. There are a lot of other immunotherapies under study in combination with chemotherapy in the frontline setting. So the way things work in oncology in general is drugs are initially found to be effective in a more advanced disease setting. And if they then look to be effective, they're moved into the earlier or frontline treatment. And so these are 3 randomized trials which are underway, looking at standard frontline chemotherapy with paclitaxel and carboplatin, with a randomization to either receive one of the immunotherapy checkpoint inhibitors, either pembrolizumab, atezolizumab, or dostarlimab. These are all 3 of these are checkpoint inhibitors, and all 3 of these are, again, randomized trials in the frontline setting, looking to see whether chemotherapy plus immunotherapy is more effective than chemotherapy alone. These are all randomized trials in terms of reducing the risk of recurrence. So some key takeaways based on this fairly new data for immunotherapy and endometrial cancer is that all endometrial cancer patients should have the tissue tested for mismatch repair deficiency. It's actually a routine thing that the pathologists do at this point. And all endometrial cancer patients are eligible for immunotherapy at this time in the second-line setting until we have some results in the frontline setting. So for patients who do have this mismatch repair deficiency or inability to fix errors that are found during DNA replication, pembrolizumab monotherapy or pembrolizumab alone is the standard of care. And for patients who don't have that deficiency, combination of pembrolizumab plus lenvatinib is currently the standard of care. There are many ongoing trials to broaden immunotherapy options in endometrial cancer. And as I mentioned on an earlier slide, actually, the side effects of immunotherapy to know about are essentially autoimmune inflammation of any organ. So what we talked about earlier, thyroiditis, colitis, pneumonitis, when your immune system is revved up too much against normal cells. So I'm going to switch gears for a moment and talk a little bit about endocrine or anti-estrogen therapy for endometrial cancer. So my practice is, I have a lot of breast cancer patients in my practice, as well as some gynecological malignancies. And so anti-estrogen medications are very commonly used in hormone receptor positive breast cancer. That is breast cancers that have present on the surface of the cells the estrogen receptor and or the progesterone receptor. And about 66% of breast cancers are what we call hormone receptor positive. But some patients with advanced estrogen receptor positive cancers that are endometrial cancers, these are generally low-grade cancers, the ones that are well differentiated. Endocrine therapy, and when I say endocrine therapy, I mean anti-estrogen therapy, is an acceptable alternative to chemotherapy, particularly for those patients who wish to avoid the side effects associated with chemotherapy, or for those with minimal symptoms or more slowly growing disease. Endocrine therapy can also be used as a later line option for those who have progressed on chemotherapy or immunotherapy-based options, or just patients who need a chemotherapy break. Just gonna open a window here because it's about 100 degrees in this room, sorry. Okay, so endocrine therapy for endometrial cancer. Endocrine therapy is well tolerated and lacks the usual side effects associated with chemotherapy. Approximately 30% of women with endometrial cancer respond very well to endocrine therapy. And while most or many of the remissions are partial and relatively brief, some patients may have a good run of their cancer being under control for an extended period of time of more than 2 years. In addition to endometrial cancer, endocrine therapy also has moderate activity in ovarian cancer, and a good example of when we use endocrine therapy for ovarian cancer is, for example, when someone has a CA-125 elevation with a normal scan. This is what we call a marker-only relapse, where the tumor marker CA-125 is elevated after primary treatment, but a scan is completely normal. That's someone that we'd be reluctant to give toxic chemotherapy to if there's nothing visible on the scan. However, we want to intervene in some way because we believe that this elevation in CA-125 is a early harbinger of what may be a recurrence in the near future. And so frequently endometrial cancer has a role in that particular setting for ovarian cancer. So in terms of different types of endocrine therapy, so one of the major categories of endocrine therapy are what are called the aromatase inhibitors. And there's 3 of them that are commonly used. One is anastrozole, second is letrozole, and the third one is exemestane. And these drugs only work when truly in postmenopausal women or women who have had their ovaries removed, or because they basically, when the ovaries are no longer producing estrogen, what is the main source of estrogen in postmenopausal women? And that is that the adrenal gland makes estrogen precursors that are converted to estrogen in your peripheral muscle and fat tissue by an enzyme called aromatase. So if you inhibit the conversion of estrogen precursors to estrogen by an aromatase inhibitor, that causes total estrogen deprivation. You can imagine that wouldn't work if the ovaries were still producing estrogen, because this is a relatively small contributor to estrogen, but it's the only contributor to estrogen production in postmenopausal women. So this would be a therapy that could be used in someone who's had their ovaries removed, who was already in a natural menopause, or if given to a younger woman, would need to be done in combination with a medication that suppresses the ovarian production of estrogen, such as Lupron or Zoladex. These are medicines that can be given that imitate menopause in premenopausal women. Aromatase inhibitors work best in endometrial cancer when they are combined with other biologic targeted therapy, primarily one called everolimus. Everolimus is a targeted therapy that inhibits one of the pathways that makes cancer cells grow abnormally. And studies have shown that this drug everolimus in endometrial cancer, when combined with aromatase inhibitors, makes the aromatase inhibitor work better and work longer. So it's kind of a drug that, as in all cancer therapies, cells have the ability to outsmart whatever treatment that you're on and become resistant. Adding everolimus to an aromatase inhibitor delays or helps prevent resistance to the aromatase inhibitor. So because these aromatase inhibitors cause complete estrogen deprivation, you would imagine that there are a lot of side effects associated with these drugs, not chemo-type side effects, but side effects of estrogen deprivation. And fortunately, over the last number of years, and this is more based on studies that have been done in breast cancer, but certainly can be extrapolated, and the title of this slide is Quality of Life, or QOL, on aromatase inhibitors. So what are the most common side effects with that estrogen deprivation? One of the most common side effects, interestingly, is actually joint pain. So it's not actual damage to a joint like arthritis, but it can feel like arthritis. And different things have been studied and shown to be helpful. So women who are physically active, and we tend to try to recommend, if people feel well enough, to have a goal of walking for 30 minutes, 5 days a week. Exercise has been shown in randomized trials to significantly decrease the joint pain associated with estrogen deprivation. Cymbalta is a drug actually in the antidepressant family, but it also has some pain effects, and also has been studied for joint pain specifically in women who have joint pain from aromatase inhibitors, and definitely has been shown to significantly decrease pain scores. Likewise, there was a very well done study looking at the role of acupuncture for the treatment of joint pain secondary to estrogen deprivation. It was a very well designed study in that there were 3 arms. There was a group of patients who received no intervention, a group of patients who received sham acupuncture, so fake acupuncture, not at the appropriate points where you would be using to treat joint pain, and real acupuncture. So the purpose of the sham acupuncture group is to rule out that it's not just the additional benefit of an extra practitioner and time spent with the practitioner that actually shows the improvement. And interestingly, there was a big benefit for the patients who were receiving the targeted real acupuncture, whereas sham acupuncture or no treatment had no effect on pain scores. And so acupuncture is a well-studied technique specifically to help with the joint pain from aromatase inhibitors or estrogen deprivation in general. So one other common side effect of estrogen deprivation are hot flashes. And fortunately, there have been a number of studies looking at various medications that can help with hot flashes. But in addition, if you want to go a more natural route, acupuncture has also been studied in women with hot flashes, and is a very effective therapy in reducing the frequency and the intensity of hot flashes. But other medications such as Effexor, which is actually in the antidepressant family, but has been shown to be an effective drug for the treatment of hot flashes, gabapentin, which is otherwise known as Neurontin, as well as a drug called oxybutynin. Oxybutynin at much higher doses is a drug that we use to treat women with urinary incontinence, but it was studied in a group of breast cancer patients with hot flashes at a much, much lower dose, and it was really shown to be quite effective, again, in reducing the frequency and the intensity of hot flashes. Vaginal dryness is something that's certainly an issue with estrogen deprivation. And, we counsel women on, non-hormonal lubricants as well, such as, coconut oil and other products such as Reverie, et cetera. But even in patients with hormone receptor positive breast cancer, low dose vaginal estrogen has not been shown to have much in the way of systemic absorption or shown to increase the risk of recurrence. And so vaginal estrogen is considered safe in cancer survivors, even when the cancers are hormonally driven. Aromatase inhibitors can cause, because their total estrogen deprivation can also cause bone loss or osteopenia or osteoporosis. And there are drugs that can help protect your bones from the effects of estrogen deprivation. Denosumab, which is also known as Prolia, or zoledronic acid, otherwise known as Zometa, are drugs that have been shown to protect the bones from the estrogen deprivation, prevent fractures, etc. So there are things to do for these side effects associated with aromatase inhibitors. Shifting gears, another well-known endocrine therapy is tamoxifen. So tamoxifen has a quite different mechanism of action than the aromatase inhibitors do. Again, the aromatase inhibitors work by cutting off the estrogen production in your body, so there just isn't estrogen floating around. Whereas with tamoxifen, there's still some estrogen floating around, but it interacts with the estrogen receptors, which may be present on some cancer cells. So it's called a selective estrogen receptor modulator, or SERM. And that inhibits the growth of cancer cells that are dependent on hormones for growth by actually blocking the estrogen receptor on the surface of the cell. So whatever estrogen you have floating around still can't get to the cancer cell, kind of like blocks the receptor. And so you still have the estrogen floating around, but it can't feed the cell that needs estrogen to grow. And tamoxifen is an interesting drug because depending upon the part of the body that it's interacting with, it can either block the receptor and act as an anti-estrogen, or it can actually interact with the receptor and act as an estrogen. And that's where you get this interesting mix of side effects. So because of the estrogen activity of tamoxifen, there is a slightly increased risk of blood clot associated with tamoxifen, similar to what we see with oral contraceptives or hormone replacement therapy. Interestingly, in patients who do have a uterus, and this mostly applies to breast cancer patients in whom we use a lot of tamoxifen, there is a very slight increased risk of endometrial cancer from tamoxifen. This is less than 1%. And in women with endometrial cancer who have undergone hysterectomy, tamoxifen, paradoxically, even though it slightly increases the risk of endometrial cancer for women who still have a uterus, actually is an excellent treatment for uterine cancer in women who are post-hysterectomy. Because of its anti-estrogen, and that's effect on the uterine lining is that tamoxifen actually acts as an estrogen on the uterine lining and not an anti-estrogen the way it does in other tissues. Like the aromatase inhibitors, tamoxifen can also cause some symptoms of estrogen deprivation, such as hot flashes and vaginal dryness, and we very frequently use the same armamentarium for interventions for those side effects that we can use for aromatase inhibitors. And interestingly, because tamoxifen does have part estrogen stimulating activity, it's actually good for the bones, helps prevent osteopenia or osteoporosis because it acts as an estrogen on the bone, and also helps promote a healthy cholesterol profile because it acts as an estrogen in the heart. Other type of endocrine therapy, there is a drug called fulvestrant, which is an intramuscular monthly shot in the tush. It acts completely differently from the aromatase inhibitors, which, just to review, aromatase inhibitors get rid of every last bit of estrogen. Tamoxifen blocks the receptor on cancer cells, and fulvestrant, interestingly, gets rid of the receptor. So it's what's called an estrogen receptor degrader or downregulator. So it gets rid of the receptor on the cancer cell, so it can no longer be fed by estrogen. And fulvestrant has been shown to have moderate activity in both endometrial and ovarian cancer. And because it's a very targeted therapy, it's extremely well tolerated when compared to either aromatase inhibitors or tamoxifen. Other endocrine therapies, well, progestins have a role in the treatment of endometrial cancer as well. So progesterone agonist drugs called Megace or megestrol acetate have been shown to be quite effective treatment in patients with advanced endometrial cancer in a regimen specifically where it alternates with tamoxifen for advanced hormone receptor positive endometrial cancer and has good activity. But Megace can also increase the risk of blood clot and also increase appetite. That's been associated with Megace, so can lead to weight gain, but can actually be a useful drug in some patients who may have more advanced cancer and have problems with their appetite. Just to put a shout out to a relatively newer biologic or targeted agent that's been shown to have activity in uterine cancer, endometrial cancer, is a drug called trastuzumab, and the brand name for that is Herceptin. And HER2/neu is a protein that is expressed on some cancer cells. It's expressed on some breast cancer cells, some gastrointestinal cancer cells, and it has been shown to be overexpressed in a subtype of endometrial cancer, which is called papillary serous cancer. And so it's now common to test this specific pathological subtype of endometrial cancer, which is called papillary serous. This tends to be a high-grade form of endometrial cancer. And we do test to see if this HER2/neu protein is abnormally overly expressed on these cancer cells. And in these patients with papillary serous cancer of the uterus that is HER2 positive, there was a randomized trial which compared primary therapy with carboplatin and paclitaxel. Paclitaxel brand name is Taxol, of course, with a randomization plus or minus to this trastuzumab. The trastuzumab is a targeted antibody to the HER2 protein. And the addition of adding this targeted therapy to the chemotherapy significantly increased the effectiveness of the chemotherapy. So this is now a receptor that must be checked on pathology for this papillary serous subtype of uterine cancer. The main side effect that we see with this targeted therapy is that it has a very, very low risk of damage to the heart, mostly the pumping action of the heart. And that's something that can be monitored with an echocardiogram, which is an ultrasound of the heart, looks at the pumping action of the heart. And that's a test that is done at baseline prior to starting the trastuzumab and is generally monitored every 3 to 6 months on patients who receive trastuzumab. What's important to note about the potential low risk of cardiac toxicity plus trastuzumab is if you do see a drop in the pumping action of the heart on a subsequent echocardiogram and you stop the drug, in 99.999% of cases, it's a reversible side effect, and the drug can usually even be reintroduced safely after a break. And that's actually all I have in terms of slides. I wanted to leave ample time for questions, and so I'm happy to open it to the audience.
That was amazing. Thank you so much.